So I'm back again, this time as chair of the plenary session. As I mentioned to you, the Thailand Hub of Talent in Cancer Immunotherapy, or in short as TTCI. This is our second year that we got support from the National Council of Research Council of Thailand. So we have, a member of TTCI join us today. So it's my great honor to introduce the session that TTCI was help organize this today. So I'll ask my co-chair to introduce the first speaker.
Good morning. Good morning, everyone. I'm Dr. Wudhikarn, a co-chairperson of the session, and I'm joined by Dr. Natya Hirangan from Chulalongkorn University. So as a reminder, a Q&A period will follow each presentations. The attendees may approach the microphone in the aisles and ask questions. So the very first session will be presented by Professor Kitsada Wudhikarn from Chulalongkorn University with the topic of challenge in delivering cellular therapies for transplant recipients and cancer patients. Dr. Wudhikarn is a hematologist with expertise in hematological malignancies, particularly lymphoma. He has dedicated himself to abundant researches, focusing on adoptive cellular therapy, including hematopoietic stem cell transplantation, chimeric antigen receptor or CAR T cells, and novel immunotherapy. Now I'll turn it over to the first presentation.
Thank you so much for a very kind introduction, and good morning, everyone. First of all, I would like to thank the organizing committee and TTCI for giving me this opportunity to participate in this esteemed symposium. And today I'm talking on the topic entitled Role of Transplantation versus CAR T-cell therapy in relapsed large B-cell lymphoma. With the given limit of time, I twist the topic a little bit in order to cover all aspects of the transplant and CAR T-cell. And I do not have any conflict of interest. And this is the outline of my talk today, that I will walk you through the role of transplant and CAR T-cell in the different setting of relapsed refractory large B-cell lymphoma. I will start with a case. We have a 40-year-old male with diagnosis of diffuse large B-cell lymphoma, stage 3AX, diagnosed back in April 2022. He presented with chest tightness, chronic cough, and subsequently noticed left cervical lymphadenopathy. Biopsy of the cervical lymph node showed diffuse large B-cell lymphoma. He received 6 cycles of ARSHOP followed by mediastinal radiation, but unfortunately, end of treatment PET-CT scan showed progressive disease. He was then salvaged with ECHAP for 3 cycles. CT after 3 cycles of ECHAP showed partial remission. At that time, he was referred to my clinic to be evaluated for a consideration of transplantation versus CD19 CAR T-cell. This is the PET scan at the time of evaluation. He still had FDG-avid lesion at the left thoracic cavity and also intra-abdominal lymph node. As you may know already, that diffuse large B-cell lymphoma is the most common subtype of lymphoma, encompassing approximately 30% of all non-Hodgkin lymphoma in US. And data from Thailand registry, DLBCL consists of 60% of all cases of lymphoma in Thailand. DLBCL has a heterogeneous cause with various natural history and prognosis. The standard treatment of this entirety is rituximab-based immunochemotherapy, which could kill approximately 60% of these patients, meaning that 40% of these patients relapse or progress after ARSHOP-based chemotherapy. And the prognosis of this patient was quite poor, especially patients who progress on ARSHOP or relapse early after ARSHOP treatment. Back in mid-1990s, there was a study named a PAMA study which explored the role of transplantation in relapsed refractory aggressive lymphoma. And this pivotal study demonstrated the benefit of autologous stem cell transplant in patients with relapsed refractory aggressive lymphoma over salvage chemotherapy without transplantation. Since that time, autologous stem cell transplant has become standard of care for patients with chemosensitive relapsed refractory diffuse large B-cell lymphoma and has been incorporated in many international guidelines. However, PAMA trial was conducted in pre-rituximab era. Subsequently, when we look at the role of transplantation in the rituximab-based chemotherapy era, it showed that the benefit of transplantation in patients with relapsed refractory diffuse large B-cell lymphoma who relapse after R-CHOP-based chemotherapy is diminishing. You can appreciate from these survival curves that outcome of patients after transplant is still disappointing, especially in patients who relapse after rituximab-based immunochemotherapy. Based on the result of that study, one could project that if we have 300 diffuse large B-cell lymphoma, approximately 100% would relapse after R-CHOP chemotherapy. And eventually, we would be able to rescue only 10 patients with autologous stem cell transplantation, emphasizing that the limited efficacy of transplant in the era of immunochemotherapy. When we look further in detail on the result of the CORAL study that I showed you before, there were approximately 220 patients who failed second-line salvage chemotherapy and could not go on to autologous stem cell transplantation. This patient would have very disappointing prognosis with median overall survival of only 4.4 months. So we would be able to tell that there are several limitations of transplantation for patients with relapsed refractory large B-cell lymphoma, and the major cause of death and treatment failure after transplantation in this patient is progression of disease. And among these high-risk patients, the highest risk group of patients include patients with primary refractory disease, patients who did not respond to second line or later line of salvage chemotherapy, or patients who relapse early after transplantation. The SCHOLAR-1 study looked at this patient population and showed that the median overall survival of this patient was quite poor at 6.3 months. In the past, the option of these patients was quite limited, and the prognosis of this patient was dismal. However, since 2017, there have been several novel therapy which has been approved to become standard of care in the space of relapsed refractory large B-cell lymphoma. Among this novel treatment, CAR T-cell therapy has been one of the novel innovation that offer hope to this patient. You can see the red highlight box that there are different CAR T-cells that have been approved over the past 7 years. And when we talk about CAR T-cell for patients with B lymphoid malignancy, including diffuse large B-cell lymphoma, there are several potential targets that could be used as a target for CAR T-cell. Among all targets, CD19 has been most extensively studied and has been approved as a standard CAR T-cell for treatment of these patients. Currently, we have 3 different CD19 CAR T-cell approved for treatment of relapsed refractory large B-cell lymphoma, acicaptagene cellular, T-cell, and lysocaptagene malablucel. When they were first studied, they were first explored as the third or later line treatment for patients with relapsed refractory large B-cell lymphoma. There are 3 pivotal trials that look at the safety and efficacy of these 3 CD19 CAR T-cell for patients with relapsed refractory diffuse large B-cell lymphoma. Julia study for T-cell, Suma-1 for Acicel, and Transcend NHL-001 for Lysocell. And these 3 studies demonstrate safety and efficacy of these 3 different CD19 CAR T-cell therapy in patients with diffuse large B-cell lymphoma, offer durable remission and long-term survival to these patients who once very difficult to treat. There was also an indirect match comparison comparing the outcome of patients treated with CD19 CAR T-cell from Suma-1 study and standard of care from the cohort of SCOLAR-1. And this comparison showed that patients who were treated with Acicel had superior survival compared to historical cohort, which were treated with standard of care from SCOLAR-1 study. Subsequently, CD19 CAR T-cell was explored in the setting of second-line treatment, comparing with standard treatment, which was salvage chemotherapy and autologous stem cell transplantation. There are 3 pivotal trials: Belinda study for T-cell, Suma-7 for Acicel, and Transform for Lysocell. Each 3 studies compare different CD19 CAR T-cell with standard treatment. This table summarizes the design and patient population, including the endpoint of these 3 studies. 2 out of these 3 studies were positive study meeting primary endpoint. Suma-7, which compare Acicel to standard of care, and Transform, which compare Lysocell to standard of care. These 2 trials show that CD19 CAR T-cell offer superior event-free survival to patients who were treated with CD19 CAR T-cell. And recently, the final analysis of Suma-7 also demonstrates superior overall survival of patients who were treated with Acicel compared to patients who were treated with standard of care. When pull all the patients together, there is a meta-analysis showing that CD19 CAR T-cell offer the benefit in terms of progression-free survival and overall survival against standard of care, which was salvage chemotherapy and autologous stem cell transplantation. After all these trials came out, CD19 CAR T-cell was approved as the standard treatment for patients with relapsed refractory large B-cell lymphoma, both as a second line and third line or later lines of treatment. With this, CIBMTR look at the activity of cellular therapy in US, and you can appreciate that there is a declining of autologous stem cell transplant activity in US since 2017. With this, I would question if there is still a role of transplantation in patients with relapsed refractory large B-cell lymphoma when we have CAR T-cell therapy. In fact, CIBMTR recently looked at patients with relapsed refractory diffuse large B-cell lymphoma who were still chemosensitive to salvage treatment. And this data showed that autologous stem cell transplant, when offered even at later line of treatment, still offer long-term progression-free survival and overall survival to these chemosensitive patients. There was also a study from CIBMTR looking at patients who achieved partial remission through salvage chemotherapy, and one received autologous stem cell transplant and the other group received CAR T cell therapy. And it turned out that patients with chemosensitive partial remission also had better outcome with autologous stem cell transplantation, both like progression-free survival and especially overall survival. What about patients who achieve complete remission after salvage chemotherapy? There was a data from multi-institution cell therapy consortium showing that this patient, when received CD19 CAR T cell therapy, had very promising outcome, indicating that lower disease burden at the time of CD19 CAR T cell therapy had a very strong impact on the outcome of CD19 CAR T cell treatment. However, when CIBMTR looked at the outcome of patients who achieve complete remission after salvage chemotherapy, again comparing between those who received transplantation and those who underwent CAR T cell, patients who were in complete remission and underwent autologous stem cell transplantation had superior progression-free survival and overall survival over patients who received CAR T cell therapy. So with this recent data, there might still be a place of autologous stem cell transplant in patients who is still chemosensitive. Besides the efficacy that we use to determine the role and recommendation of a cellular therapy, we cannot deny the side effect and cost effectiveness when we recommend the treatment to our patients. As you may already know that CD19 CAR T cell had several unique side effects ranging from acute immune-mediated complication, either CRS or ICANS, organ toxicity to delay adverse events, including prolonged hypogammaglobulinemia, prolonged cytopenia, and increased risk of infection. This table summarizes the incidence of CRS and ICANS, including prolonged cytopenias of CD19 CAR T cell in different studies of relapsed refractory diffuse large B-cell lymphoma, both in the clinical trial setting and real-world study. And when we look at the non-relapse mortality from these adverse events from CAR T cell therapy, most of non-relapse mortality occur at the later time point after CD19 CAR T cell. And the major cause of death of patients who receive CD19 CAR T cell is infection. And there is a meta-analysis looking at the non-relapse mortality estimate of 7,000 patients from 18 clinical trials and 28 real-world studies. Focusing on the non-relapse mortality after CAR T cell in patients with relapsed refractory diffuse large B-cell lymphoma, 1 year non-relapse mortality of this patient is approximately 6.1%. And the major cause of death is infection in approximately half of the patient. This figure again highlights you that patients with diffuse large B-cell lymphoma, when they receive CD19 CAR T cell, had 1 year non-relapse mortality of 6.1%. And among 3 different approved products, Axi-cel had the highest non-relapse mortality at 7.4%. What about the non-relapse mortality of autologous stem cell transplantation? EBMT looked at patients with relapsed refractory large B-cell lymphoma who underwent autologous stem cell transplant from 1990 to 2021. in approximately 40,000 patients. 1 year non-relapse mortality of this patient has ranged between 4 to 6%, which is comparable to patients who receive CD19 CAR T cell therapy. So when looking at the meta-analysis comparing safety profile of CD19 CAR T cell and standard of care, it seems to be comparable. For the cost effectiveness, we have to admit that most cost effectiveness analysis to date indicate that CD19 CAR T cell may not be cost effectiveness yet compared to second line and third line standard of care at 200,000 Kali years. And this one is the cost effectiveness analysis for CAR T cell as second line treatment, and this one is as the third line treatment. Both of which still show that CAR T cell is not yet cost effectiveness. There are other limitations of CAR T cell, whether the patients still can relapse or develop resistance. There are several efforts to improve CAR T cell, toxicities of CAR T cell, and logistic and manufacturing process, which still had long waiting time. There are several studies that try to improve this a limitation of CAR T cell, and hopefully we will have newer treatment that can offer better CAR T delivery to the patients. And when we look at the distribution of the patient, we could appreciate that when we start with patients with relapsed refractory diffuse large B-cell lymphoma, approximately 75% of the patient would fall into CAR T-cell category, and the other 25% of the patient would still be considered for autologous stem cell transplant. So the most important thing would be patient selection. When we have patients, one may consider eligible for both CAR T cell and transplant. One may be eligible for just only CAR T cell, or one may not be eligible for either CAR T cell or transplantation. And when we look at the most recent CAR T cell and transplant consensus statement for autologous stem cell transplant and cellular therapy from United States. There are still a role for autologous stem cell transplant in patients with chemosensitive who relapse after 1 year. But for patients who relapse within 1 year or refractory to first line treatment, this patient should be considered for CAR T cell therapy. So get back to our patients. He was decided to be enrolled to receive CD19 CAR T cell under clinical trial. He received CD19 CAR T cell and developed CRS grade 2, which respond to tolicizumab. He did not have ICANS. He was discharged on day 14. PET-CT scan at 1 month and 3 months show complete metabolic response. Patient is currently 1.5 years after CAR T cell therapy and remain in complete remission, but he has ongoing hypogammaglobulinemia. This slide compare the pre-treatment PET-CT scan and post-treatment PET-CT scan, which show complete metabolic remission of these FDG avid lesions. The last part of my talk, I would like to highlight the work at our hospital as the limitation of CAR T cell in Thailand and many Asian countries is the access to CAR T cell. Our hospital strive to offer best care to our patients in Thailand. We develop and try to initiate CAR T cell program at our hospital, although we are at the beginning and we could appreciate the increasing activity of CAR T cell over the past recent year. This slide summarizes the proportion of patients by of the CAR T cell activity by product, by disease, and by our program. Most common indication is B-cell lymphoma, and of this patient, most of the patient are diffuse large B-cell lymphoma. This show the response rate of CAR T cell in B-cell non-Hodgkin lymphoma according to the product. We have two products at our hospital, piggyback transposon technique and Prodigy Clinimac point of care, and the overall response rate approximately 70% for both products. And these are the survival of the patients who received CAR T cell product at our hospital. These patients who were once difficult to treat could achieve approximately 80% 2 years overall survival. In conclusion, CD19 CAR T cell has become standard of care in patients with early relapse and refractory large B-cell lymphoma. Despite the result, autologous stem cell transplant has remained standard of care in young and fit patients with chemosensitive relapsed diffuse large B-cell lymphoma who receive at least